Hello, this is Lee Schwartzberg. I'm Chief of Division of Hematology and Oncology and Professor of Medicine at the University of Tennessee at the West Cancer Center. And it's my pleasure to present this webinar entitled Post ASCO Immunotherapy Highlights, Part 1. And we're going to talk today about checkpoint inhibition and CAR T cells. Next slide, please. So the objectives of this webinar are first to provide an overview of clinical data on immunotherapy released at the ASCO annual meeting, which took place last month in early June 2016. To discuss key clinical studies presented at ASCO on first checkpoint inhibitors. To talk a little bit about the key clinical emerging data on combination immunotherapies, and to outline the latest development in CAR T therapies. Next, please. So I don't have to tell the audience that we're in an era where immunotherapy and immuno-oncology is resurgent and really looks to dominate the field of oncology. And this is a very welcome development. And one can certainly think about immuno-oncology as a fourth tier of the way we treat patients, including surgery, radiation, chemotherapy, and now immuno-oncology. And the results from the numerous drugs that are being tested in the immuno-oncology space are coming fast and furious. Just as an example of that, if you look here, you see that focusing on immunotherapy abstracts that were presented at ASCO, there were less than 10 in 2012, and it's doubled every year. And this year, we have over 400 abstracts on immunotherapy, representing about 10% of all the abstracts in ASCO on every topic. And as you can see, the majority of those are so far focused on checkpoint inhibition. We have drugs that are checkpoint inhibitors, and they're already used in the clinic, and we'll hear some of the latest data in just a minute. Also, a lot of data on biomarkers, specifically the anti-PD-1 and anti-PD-L1 markers and the use of those particular drugs, and an emerging field, which we're going to hear much more about in the years to come, is adoptive cell transfer, and we'll talk a little bit about that today as well. So this is an area where clearly there is tremendous resources being placed both in academia and pharmaceutical industry to develop immunotherapy drugs. And the reason that this is going forward is because these drugs work. And what we have found is that as we understand the biology better of the immune system, we can target many of the complex pathways and regulatory components of the immune system and generate clinically meaningful results by basically allowing the immune system to attack the cancer. Next, please. So we're going to focus a fair amount of attention on the checkpoint inhibitors, and we're going to talk about monotherapy with checkpoint inhibitors in 3 situations: in head and neck cancer, in urothelial carcinomas, and in renal cell cancer. And we're going to talk about combination therapy of checkpoint inhibitors with other drugs in melanoma, lung cancer, and triple-negative breast cancer. So what this tells you is that checkpoint inhibitors are being tested and employed in a large variety of cancers. And in fact, there is evidence that across many different disease states, there is good activity, varying activity for monotherapy and increasingly combination therapy used in these diseases. So we're making great progress, and the field is moving very fast. Next, please. So these are the drugs we're going to talk about. I believe there are 7 individual agents that we're going to talk about. Atezolizumab, which is a PD-L1 inhibitor, alone or in combination. Nivolumab, which is PD-L1 inhibitor, which is not yet approved as a single agent. Durvalumab, a single agent PD-L1 inhibitor, not yet approved. Nivolumab, a PD-1 inhibitor, which is approved alone in monotherapy or in combination. Pembrolizumab, a drug that is also approved PD-1 inhibitor alone or in combination. So I think you can see the theme that there are multiple checkpoint inhibitors, either PD-1 or PD-L1 inhibitors, and they're being tested as individual agents and then in combination, particularly after they are approved. Next, please. So I want to refresh the audience's memory about how checkpoint inhibitors work. Now, we understand today there is irrefutable evidence that what has been suspected for decades, which is that the immune system is locked in a battle with cancer cells when they develop. And we believe that in many cases immune surveillance can eradicate evolving tumors in a body before they become clinically evident. But cancers are very smart, and they've developed mechanisms to subvert the immune system and to put the immune system into a dormancy situation so that so that your innate immune system does not attack an evolving cancer. And there are checkpoint inhibitors work on two aspects of the immune system. The first is that in T-cell activation. T-cell activation is an early part of the immune system, and T-cell activation occurs when antigen-presenting cells, like dendritic cells, interact with T-cells, which then are primed to develop an immune response against particular antigens. The way that checkpoint inhibitors work is that there has to be an interaction between the antigen-presenting cell and the T cell. And actually, that works. It's actually a co-stimulatory molecule, of which one part of it is the CD28 molecule, which is found on the surface of the T cell, and that binds to a molecule called B7 on the APC. The other part of that, which is not shown on this, is a linkage between the major histocompatibility complex 2, which is also, so two signals are required here. But the CTLA-4 is an inhibitory molecule which prevents the activation of the T cell through the APC. And ipilimumab, and it's a natural, and CTLA-4 is a natural part of our immune system, so we don't overstimulate the immune system, but tumor cells use this to subvert the immune system. Ipilimumab, which was the first checkpoint inhibitor approved by the FDA several years ago, initially for melanoma, interferes with that inhibitory response and allows the stimulatory response between CD28 and B7. And so then the T cells become primed. So once T cells are primed, they're then expanded and they form cytotoxic T cells, which are effector cells, which can directly kill cancer cells. But the cancer cell, again, has another way of disguising itself and inhibiting the immune system from killing it, and that's through the PD-1, PD-L1 axis. So PD-1 is, as you can see in the right-hand portion of this figure, is a molecule that is expressed on tumor cells as well as many other cells. And PD-1 interacts with PD-L1, which is the ligand, and that interaction inhibits the cell. So the T cell from activating and killing the tumor cell. So we can inhibit that pathway by using an antibody, and we have two flavors of the antibody. As shown here in yellow is a PD-1 inhibitor. So PD-1 is found on the T cell, And PD-1 will inhibit its interaction with PD-L1 and therefore turn off that inhibitory stimulus. Or we can actually inhibit the ligand itself, which again is found on tumor cells and other stromal cells. And so we can inhibit either way. We can either inhibit the receptor, PD-1, or we can inhibit the ligand, PD-L1. And both of these have been shown to work. So basically, once we inhibit this pathway, this allows the T cell to recognize the tumor cell and to cause lysis and death of the tumor cell. So this is the basic principle behind using checkpoint inhibitors. Now, these are not the only checkpoints that can be exploited in the clinical setting, and you'll see some work on others. But these checkpoints, which are inhibitory molecules, these are the first two systems that have been successfully utilized by developing drugs against them. Next slide, please. So let's turn to the clinical data. First, we're going to talk about recurrent or metastatic head and neck squamous cell cancer. This is a cancer that has a few chemotherapy drugs that work, but it tends to be a resistant cancer when it becomes metastatic. And there's been a lot of excitement about using the checkpoint inhibitors in this particular disease. So this is a study called CheckMate 141, which is a phase 3 randomized study which enrolled patients with recurrent or metastatic squamous cell cancer of the head and neck. It's a large trial, 361 patients. These patients had all been previously treated, and they were randomized to either receive the checkpoint inhibitor Nivolumab or a chemotherapy of physician's choice, which could be methotrexate, docetaxel, or cetuximab. All of the patients enrolled in this phase 3 trial had had previous chemotherapy, and half of them had had 2 or more previous lines of chemotherapy. In this study, they were enrolled regardless of their PD-L1 status, although it was checked on all patients. So the overall response rate was for PD-L1 positive patients, as defined in this study, of greater than 1% positive, 17% for Nivolumab versus 1.6% for chemotherapy. And in the patients who did not express PD-L1, still 12% of patients responded to Nivolumab versus 10% to the chemotherapy. The median progression-free survival was slightly better. It was essentially the same, but the 6-month progression-free survival was better for Nivolumab. What was important in this trial was the overall survival. Overall, the median survival was 7.5 months for Nivolumab versus best chemotherapy, which was 5 months, and that was a statistically significant hazard ratio, a 30% improvement in median overall survival. The 1-year survival for Nivolumab patients doubled compared to chemotherapy and was 36% versus 17% for chemotherapy. If you look at the survival by PD-L1 expression, the median survival was almost double for patients who had PD-L1 expression at least 1% if they received Nivolumab. And for the patients who had no expression of PD-L1, the median survival was similar whether they got chemotherapy or Nivolumab. Importantly also, the grade 3-4 treatment-related adverse events were almost 1/3 as frequent for Nivolumab compared to chemotherapy, despite the fact that these patients received single-agent chemotherapy, again, cytotoxic chemotherapy, docetaxel, methotrexate, or cetuximab. So these results are, I think, very interesting. And on the basis of these results, Nivolumab was designated as a breakthrough molecule from the FDA and will be evaluated further. Next slide. Now, the other PD-1 inhibitor, pembrolizumab, has also been tested in recurrent and metastatic head and neck squamous cell cancer. And this slide shows you the data. Now this pembrolizumab is a little bit earlier in development. So there was a phase 1 expansion cohort in the KEYNOTE-12 study, which was a large trial that had many different slots for different diseases. And this did accrue 192 patients in the phase 1 expansion. And these patients were treated in the expansion phase not at a weight-based dose, which is the way that pembrolizumab has been approved on an every 3-week basis. But patients in the KEYNOTE-12 phase 1 expansion received a fixed dose of 200 milligrams every 3 weeks. 45% of the patients in KEYNOTE-12 had greater than 3 lines of therapy, and half of them had previously received platinum-based therapy and cetuximab. So this was a very heavily pretreated group of patients. And the overall response rate for patients who had a PD-L1 that was positive, as defined of at least 1%, was 18%, very similar to the nivolumab data, if you recall. And again, the median progression-free survival was 2.2 months, very similar, and the median overall survival was 8 months. The grade 3 and 4 treatment-related adverse events were 13%, and these results look very similar to the nivolumab randomized results as well. KEYNOTE-55 was a single-arm phase 2 study. In this particular group, these patients were treated with metastatic squamous cell cancer of the head and neck after progression on platinum and cetuximab, so it was a more homogeneous population. And again, you can see the results are very consistent across studies and even across different agents. So we're seeing very reproducibly a response rate of about 20%. Not a tremendous progression-free survival in terms of a median, but the overall survival in this heavily pretreated population, where generally there aren't good outcomes from additional therapy, with a median overall survival of 8 months, is good. But I think one of the things we have to remember about checkpoint inhibitors is not so much the median overall survival, which is an endpoint that we've typically used for cytotoxic chemotherapy, but these drugs tend to engender, for the responders at least, a long response in a proportion of patients. And in addition, there's a proportion of patients in other diseases where the tail of the response is quite long, and some patients remain stable for very prolonged periods of time. We don't have that data yet, but as we follow these patients longer and we see the overall survival, we would hope that to see a tail of patients from squamous cell cancer of the head and neck that would be similar to what we've seen in other diseases. Also importantly, in this very heavily pretreated group of patients who tend to have comorbidities anyway and are older, the grade 3 and 4 treatment-related adverse events from the checkpoint inhibitors, nivolumab and pembrolizumab, are reasonably modest and are tolerable, with about a 10 to 15% grade 3 or 4 toxicity. And as you recall from the phase 3 trial, that was quite a bit higher even for single-agent chemotherapy in this setting. One of the things that still needs to be investigated in head and neck cancer is the effect of HPV positive or P16 positive head and neck cancer and its interaction with the checkpoint inhibitors. And there's a little bit of data now that suggests that there may be a slightly better response in HPV positive patients. And these patients who have virally activated head and neck cancer tend to have more mutations, and there's increasing evidence that patients that have more mutations in their cancer genome may generate more neoantigens and therefore may have a higher chance of response to a checkpoint inhibitor. There's emerging data in a number of cancers that may be true, and we'll have to wait for further results in the HPV setting in squamous cell cancer of the head and neck to know definitively. Next slide, please. So Again, I've talked about some of this, but the very similar efficacy and safety results between nivolumab and pembrolizumab. We have different phases of studies. I want to emphasize again that these patients were heavily pretreated, and they still derive substantial benefit, a proportion of them. We do see a higher benefit in PD-L1 positive patients, but with nivolumab, where PD-L1 negative patients were recruited, they can also benefit, although at a lower response and lower benefit than those who are PD-L1 positive. And recall that in this study, PD-L1 positive was defined as 1%. We talked about the HPV, and I will mention that pembrolizumab has what's called a PDUFA date with the FDA, which means that it has filed for approval in head and neck cancer, and we will see the results in the very near future and see how the FDA rules on whether the drug will be approved for another indication, in this case for metastatic squamous cell cancer of the head and neck. Next slide, please. Okay, we're going to shift gears now and talk about urothelial cancers. So urothelial cancers, we're talking predominantly about bladder cancer, but there are great similarities between the bladder and the epithelium of the renal pelvis through the collecting ducts and the urethra and ureter. So those tend to be lumped together when they're tested for a particular therapy. And as you can see in these trials, and we're highlighting 4 trials that were presented using 3 different drugs. So here we're looking at 3 different drugs: avelumab, atezolizumab, and durvalumab. And these are all checkpoint inhibitors, and they were tested in different phases. Avelumab and durvalumab are not yet approved drugs, but are extremely interesting. And all of these are being tested against bladder cancers and in some cases other urothelial carcinomas as shown on the slide. So if you look at the overall response rate across these drugs, you see that they range from 15 to 38%. And keep in mind that the atezolizumab trials, there's 2 studies there. One is in the first-line setting, and these are patients that were considered unfit for first-line chemotherapy because they either had a poor performance status or they were not candidates for platinum-based therapy. And so in the other cases, they were, that was the first-line study with 119 patients. In the other cases, they were second-line, and most of those patients had received first-line therapy with a platinum-containing regimen. And the second-line study for atezolizumab is a very large trial, 300 patients, with smaller phase 2 studies for avelumab and durvalumab. So again, if you see, let's focus on the first-line study with atezolizumab. The overall response rate in the first line in these poor performance status or patients with comorbidities was 24%, and that was the same if they were PD-L1 positive by more than 5%. The median overall survival was 14.8 months, and again, the grade 3/4 treatment-related adverse events was around 12%. So if you look at the grade 3 and 4 AEs again across the studies, you'll see that there tends to now be this recurring theme that these drugs do not have a tremendous amount of severe toxicity, and they range somewhere between the 5 and 15% range across different diseases and across different settings. And it doesn't seem to make a tremendous amount of difference whether or not they're in the first line or second line or advanced line setting, as I've previously shown you with other patients. So in general, these drugs are all well tolerated when we're talking about the checkpoint inhibitors. If you look across the median overall survival, we have some data for avelumab and atezolizumab in the second line, and they vary somewhat, which may relate to the small numbers in the avelumab. In the first line setting, again, the overall survival is good. The median progression-free survival is modest in the second line setting, and as would be expected. But again, I would focus more on the overall survival. So I think what we can see here is that urothelial cancers clearly respond to checkpoint inhibitors, and atezolizumab is approved for bladder cancer. And further data will be forthcoming, both in monotherapy with the other drugs as well as combination therapy. Next slide, please. So here is the indication for atezolizumab. It was approved in May 2016. These approvals from the FDA are coming very quickly for the checkpoint inhibitors. And the actual approval is patients with locally advanced or metastatic urothelial carcinoma who have disease progression during or following platinum-containing chemotherapy, or if they had neoadjuvant or adjuvant therapy with platinum-containing chemotherapy and have recurrence within 12 months. So atezolizumab can actually be given in the first-line setting, as noted by the second bullet point, if the patient has had previous adjuvant or neoadjuvant therapy. And this is, to my knowledge, the first indication for the drug in the first-line setting. Next slide, please. Okay, continuing in GU cancers, we're going to talk about advanced renal cell carcinoma. So we know that nivolumab, it's already been shown that nivolumab and pembrolizumab have activity in advanced renal cell cancers, and these are drugs that can be used in that setting. But what about after progression? We already touched on the fact that many patients have prolonged disease stability across different diseases when used checkpoint inhibitors. So this was an interesting trial that looked at continuing nivolumab beyond progression. So one of the things we know about checkpoint inhibitors is that in some cases, responses take a long time to generate, and that's somewhat different than cytotoxic chemotherapy, but not too surprising, since the way this is working is not a direct cytotoxic effect of the drug. The drug is causing stimulation of the immune system, which then has to go through a number of steps to kill the cancer. So it's not totally surprising from a mechanistic viewpoint that it takes longer when you're using a checkpoint inhibitor to see some of these results in terms of a tangible effect on a CT scan. In addition, we sometimes see pseudoprogression when we give the checkpoint inhibitors, because what part of the first response of the immune system is to cause inflammation. So sometimes lesions on CAT scans can get larger, not because the cancer is progressing, but because there's an infiltrate of inflammatory diseases as the immune system starts to work and starts to pump in these inflammatory cells and these T cells and these cytotoxic cells that are all going to eventually kill the cancer, but initially make it look like it's getting worse. So we have a lot to learn on how best to use these drugs. And in this particular study, this was CheckMate 25, which was a randomized phase 3 study, which showed the benefit of nivolumab. But they were allowed to, in this study, for patients to continue nivolumab beyond progression, and a substantial number of them did. So the interesting thing in continuing nivolumab beyond progression in advanced renal cell cancer was that 14% of patients who continued the drug then had what would be considered a partial response by RECIST criteria, or 30% tumor reduction. More importantly, the patients who continued treatment had an improved survival compared with those who did not. In fact, it was almost double at 28 months versus 15 months. So this raises a lot of interesting hypotheses and questions. Should patients who are on checkpoint inhibitor for renal cancer stay on it indefinitely and add another agent like a tyrosine kinase inhibitor after nivolumab, and can that be done safely? Whether patients who are on nivolumab, how long we should leave them on? Should we leave patients, not just in renal cancer, on nivolumab or other checkpoint inhibitors after they progress, because perhaps we'll see additional responses later, or perhaps will improve overall survival regardless of downstream therapy. This raises all kinds of new questions to test in clinical trials, and it just exemplifies the complexity of the kinds of trials that we have to do, and in order to optimize the use of checkpoint inhibitors as well as other anti-immune therapy agents. Next, please. So the area where checkpoint inhibitors were first established were melanoma, and melanoma is giving us many interesting results that we can apply both to that disease and perhaps to other diseases as well. So this was an update of the CheckMate 67 trial, which was a randomized phase 3 trial that compared single-agent nivolumab with placebo to nivolumab and ipilimumab, which is the CTLA-4 inhibitor that I mentioned before. So large study, and the overall response rate was superior for nivo and ipi compared to, and this also had a third arm, a third arm of ipi alone, which was the standard when this study was designed. So basically, what it showed is that if you compare nivo and ipi to nivo alone, nivo and ipi had a higher overall response rate, 57% versus 44%, and nivo and ipi was dramatically better than ipi alone, as you can see in the right-hand panel. The median progression-free survival for the combination versus nivo, which is really the standard now. So when the trial was started, ipi was the standard. We've seen that nivo is superior to ipi. So as a single agent, nivolumab has become the standard. But looking at the combination of nivo and ipi versus nivolumab, we see almost a doubling of median progression-free survival here, with 11.5 months versus 6.9 months, and that's a hazard ratio of 0.75. And of course, as expected, nivo plus ipi is much better than ipi. The median duration of response is not yet reached for the nivo and ipi combination versus nivo alone. But this improvement in progression-free survival, and we're awaiting the overall survival data with bated breath, because that's going to tell the tale about whether combination therapy should be given to most or all patients in the, or some subset of patients who have advanced melanoma. But there is a cost to doing the combination therapy, and that's a substantial increase in grade 3 and 4 treatment-related adverse events, and that's 56%. So, and that's despite the fact that there were only 4 doses of ipilimumab given in this particular trial, with a low dose of nivolumab during the induction phase, and then standard dosing of nivolumab 3 mg per kg every 2 weeks. So I think these are encouraging results. They're exciting results for the combination, and definitely reinforces the fact that combination immunotherapy can show greater benefit. We have to weigh the risks and the benefits of the grade 3 and 4 adverse events, which also go up. Whether or not this is the best schedule in melanoma to combine nivo and ipi is not yet known. This does work regardless of PD-L1 expression and BRAF status, because patients in this study could either be wild type or mutant BRAF. So this is another combination that clearly has benefit in advanced melanoma. Next slide, please. In an analogous fashion, pembrolizumab has been tested with ipilimumab, and in the KEYNOTE-29 phase 1 expansion cohort. And these were advanced melanoma patients, again, who had not had any previous exposure to checkpoint inhibitors, although a small percentage of them had had prior therapy. This is a single-arm study. The overall response rate was 51%, and this looks, again, very similar to what one sees with the combination of nivolumab and ipilimumab. There was a number of patients who developed a complete response here, and that's very gratifying for advanced melanoma patients. Again, the grade 3/4 treatment-related adverse events were more significant than one would see with single-agent pembrolizumab at around 38%. So these results, I think, mirror what we saw in the phase 3 trial with nivolumab, in this case in a phase 1 expansion cohort using the alternative PD-1 inhibitor pembrolizumab combined with ipilimumab. Next, please. Okay, we'll turn our attention to non-small cell lung cancer, but we're continuing on the theme of nivolumab and ipilimumab. And it makes sense to combine these drugs because they're working, as I showed you, on two different aspects of the immune system. And there is a great deal of preclinical evidence which suggests that by targeting multiple areas of the immune system and where checkpoint inhibition works, that we can get better responses. So this was a phase 1b trial, CheckMate 12, which looked at 3 different schedules of drugs for advanced non-small cell lung cancer without prior chemotherapy. Nivolumab, 3 milligram standard dose Q2 weeks as sort of the control arm. Nivolumab at the same dose with ipilimumab, 1 milligram per kg every 12 weeks, or Nivo 3 plus ipilimumab 1 every 6 weeks. So these are small groups of patients, and they should be interpreted in that light, 30, 40, 50 patients per arm. You can see that the response rate from adding ipilimumab to nivolumab went up with the ipilimumab, anywhere from 39 to 47%, so almost a doubling of response rates. And if you look at the patients who had PD-L1 positive, the response rates were even higher. Patients could be in this study with either PD-L1 positive or negative result, but those that had any positivity, 1% or greater, had a very good response rate. Over half these patients responded. In addition, the median progression-free survival was longer for the combination therapy, but once again, we see more grade 3 and 4 adverse events in the mid-30 range when you add Nivo, even at these doses. And although, despite that increased grade 3/4 adverse events, there was really no difference in the discontinuation rate. Now, there was some imbalances in this study in terms of the number of smokers, which also relates to immune response. It was only 5% in the Nivo alone arm. I'm sorry, in the Nivo plus IPI every 12 week, and 23% in the Q6 week IPI arm. So these results are somewhat preliminary, but are very exciting that in first-line lung cancer we can have a response rate of over 50% in a non-chemotherapy immunotherapy combination with hopefully acceptable adverse events. The Nivo 3 mg per kg and the IPI 1 every 6 weeks has been selected for a phase 3 trial, which is ongoing, which is called CheckMate 227, and that is accruing patients now, and we should see the results sometime in the future. Next slide, please. So here's some further data looking at the smoking status and the EGFR mutation status. Smoking status is important because one of the things we've learned with immune therapies is that patients who smoke have more DNA damage and more neoantigens and mutations, and they tend to be more responsive to checkpoint inhibitors. And that shows here that both in the Nivo alone arm and in the Nivo plus IPI arms, patients who had smoked did better. But again, we saw that the combination still did better than Nivo in each group. In the EGFR mutation, there was a very small group of patients, only 4 patients who responded with a mutation, and some of those were former smokers, so there may be confounding issues here, and I wouldn't pay a lot of attention to this yet, but it's clear that patients who have EGFR mutants do respond to checkpoint inhibitors. So recall that these patients who were in the first line did not receive a TKI targeted against their EGFR mutation yet. Next, please. So we now know that there is also a response of checkpoint inhibitors in small cell lung cancer. Small cell lung cancer is a disease where one could argue there's been no progress made of substantial benefit over the last 25 years, and we're still using platinum-based chemotherapy in the first line, and we have very modest results with any patient, and that's virtually all of them who progress after first-line therapy. So this is looking at Nivo alone or in combination, similar to what I showed you, although the doses, again, are a little different in this study for small cell lung cancer. These are all patients who had progressed after platinum-based chemotherapy. And you can see that the addition of Ipilimumab, again, a somewhat different dose here, increased the response rate, doubled the response rate, almost doubled the overall survival of these patients, which tend to be very short in the absence of any response to therapy. Again, a 30% adverse event rate, but only 11% discontinuation. So I think we're very excited about this. The Nivo at 1 mg per kg and Ipilimumab at 3 mg per kg has been selected for a phase 3 trial, which is now running in small cell lung cancer. Next slide, please. Okay, switching disease states now. This is Atezolizumab, but not combined with another immune therapy, in this case combined with chemotherapy. So this is an interesting approach in triple-negative breast cancer. Triple-negative breast cancer is a disease where clearly there's need, like in small cell lung cancer, for additional therapies. And paclitaxel or nab-paclitaxel has reasonable activity in triple-negative breast cancer, although most patients, once they get beyond several lines of therapy, don't respond very well to any chemotherapy. So in this case, this was a phase 1b study to first show that the drugs could be combined at adequate doses, which it did. The grade 3 and 4 adverse event, the major one was serious neutropenia, which is to be expected anyway in some cases from paclitaxel, but probably was increased with the addition of Atezolizumab. But what was interesting here was the response rate was 38%, and that's much higher than one would expect in patients who have previously been treated with triple-negative breast cancer. There were a few patients first line in this study who had a very high response rate, but even in those patients who had had 3 lines of therapy, 40% of those patients had an objective response, and that's very unusual for this group of patients treated with chemotherapy alone. For those patients who had a response, the median duration of response is not yet reached. However, there was a 50% discontinuation among the responders, so the drug has some chronic toxicity. These exciting results have led to a phase 3 trial on previously untreated triple-negative breast cancer of the combination of Atezolizumab and nab-paclitaxel, and that's called Impassion 130. Next slide, please. So I need to speed up a little bit so we can get done. So this is a phase 1b study of a new drug, and I'm not even going to try to pronounce it. I'll just call it UTOM. It has a name, it has a number too, but that's even harder. So I'll just call it Nivolumab. And this is a phase 1b study. Now this is an interesting drug because it's targeting a new receptor called the 4-1BB receptor. Now that's a stimulatory molecule. So we've been talking about inhibitory molecules. Now this is a drug that we're trying to engage and make the stimulation even greater here. So this is working by a different mechanism. And preclinical results had shown that the combination of UTOM and anti-PD-1 may amplify the anti-tumor response. And these were patients who were advanced solid tumors, heavily pretreated, small group, but the response rate was 26%. And those patients who respond, the median's not yet reached, and the drug was well tolerated. The combination was well tolerated, discontinuation rate of 0 in these 23 patients. So keep your eye out for this combination. I think we'll see it expand into a variety of different diseases. Next, please. So I want to now move and spend a few minutes on adoptive cell transfer. This is a different component of the immune system. in this case, we're not using antibodies against checkpoint inhibitors. We're actually using the patient's own T cells. So the T cells are collected from the blood. They're engineered ex vivo to express something called a chimeric antigen receptor, which or CAR, which recognizes tumor antigens. Then those cells, once they're defined to contain this CAR, are expanded ex vivo in culture and grown to a large number, which can then be effector cells, and then they're reinfused back into the patient. The idea is that those engineered T cells that recognize the specific antigen in an individual patient will recognize that antigen, attack it, and kill the antigen. Next slide, please. So this is some results from 2 trials from a CAR T cell or chimeric antigen receptor T cell from a company called Juno, and this is targeting CD19, which is an antigen that is found in high levels on B-cell malignancies. So they looked at this in 3 types of B-cell malignancies: acute lymphoblastic leukemia, non-Hodgkin's lymphoma, and chronic lymphocytic leukemia. And the patients who were enrolled in the 2 different studies are listed here in the columns. These were all refractory and relapsed CD19 positive B-cell malignancies. They had all been heavily pretreated, median of 3 prior lines of therapy. The results are pretty dramatic. If you look at the complete response rate for ALL in JCAR 15, 90% of patients had a response, and morphologic complete response was 77%. In the 14 trial, 100% of patients had a response for ALL, and patients with CLL or NHL who had been heavily pretreated had high response rates and a 45% complete response rate. Now, there is a cost to CAR T cells, which we're learning, and that is that there can be deaths from toxicity. And recently, the JCAR 15 trial was halted because there were 3 patient deaths which related to neurologic effects in the central nervous system. So we clearly have to learn more about how to use CAR T cells. However, I wouldn't underestimate these dramatic results in refractory cancers that have no meaningful treatments available to them. And hopefully in the future we'll be able to reduce the toxicity of these cells and continue the tremendous efficacy. But this is not yet ready for prime time. A lot more study has to be done on CAR T cells. Next, please. And this is another study using another company's CAR T cell. Kite is the company, again in NHL, 2 trials, one done at the NIH, which was low-dose chemotherapy and CAR T cells in refractory diffuse large B-cell lymphoma, and a phase 1/2 study in refractory B-cell NHL, which included other histologies. Again, very high response rates in the 70s, very high complete response rate in the 50s. Some of these are ongoing, and again, dominant toxicities are neurologic. So this doesn't seem to be one product specific. It seems to be characteristic of CAR T cells. High response rates when you have a good target, particularly so far the targets have been B-cell, liquid tumors, and lymphomas, but some neurologic toxicity. Next, please. So to summarize, a lot of data. We see some really excellent results from ASCO 2016 as it relates to immunotherapy. And I don't think it's a stretch to say that, once again, that immuno-oncology dominated the ASCO meeting for the 2nd year, at least in a row. Nivolumab improved overall survival compared to chemotherapy in metastatic squamous cell cancer of the head and neck in a phase 3 trial. Pembrolizumab in phase 1 studies showed similar efficacy and safety, almost identical actually. The PD-1 and PD-L1 inhibitors demonstrated activity in advanced urothelial cancer, and atezolizumab has been approved for urothelial cancer after progression after platinum-based therapy, either in the 1st line or 2nd line. Patients with renal cell cancer who continued Nivolumab beyond progression had improved survival compared with those who discontinued. And this sets up lots of hypotheses for how to use checkpoint inhibitors beyond progression. The combination of Nivolumab plus Ipilimumab showed higher efficacy across different disease types: melanoma, non-small cell lung cancer, and squamous cell lung cancer. So we will see, and already are seeing, phase 3 trials in solid tumors that are looking at the combination of these checkpoint inhibitors as first-line setting or second-line setting in these diseases. Combining a checkpoint inhibitor plus chemotherapy is feasible. Atezolizumab and nab-paclitaxel showed activity in triple-negative breast cancer, and this is also being tested in a phase 3 trial. New drugs like the anti-4-1BB, in this case a stimulatory antibody, appears promising and so far is safe in combination with checkpoint inhibitors. And CAR T cells, which are genetically engineered autologous T cells, and which are then grown, demonstrate high response rates in B-cell malignancies, including acute leukemia that's refractory and non-Hodgkin's lymphoma that's refractory, with some toxicities that will continue to be worked out. Next, please. So I just want to remind the audience that we will be doing part 2 because there was simply too much to talk about in immunotherapy in 1 hour. And we'll be doing our Post ASCO Immunotherapy Highlights Part 2, which is going to focus predominantly on biomarkers for immunotherapy as we go forward. And I'll just tease up the discussion by saying that there's been a lot of interest in PD-1 and PD-L1, particularly PD-L1 as a biomarker, as is expressed on tumor cells, and you saw some data, and we'll explore that data in much greater detail in Part 2. So join us again for Part 2 on July 26, 12 to 1 p.m. Eastern Time. Thank you very much, and I'm happy to answer any questions that anyone in the audience has.
Thank you so much, Dr. Schwartzberg. That was an excellent talk. We do have a few questions from the audience. And one question is, do you think upfront immunotherapy will be the trend across most tumor types? And there seems to be a lack of data in the immunorefractory setting, and a lot of patients actually do not respond to immunotherapy.
Right. So there's two different questions. So let me address the refractory or the non-responders first. So what we're seeing across multiple solid tumors is that there's variation in response to a single agent, which is where we have most of the data so far in checkpoint inhibitors. And it's true that a minority of these patients respond to single agents. So therefore, we really need to have good biomarkers to understand who are the patients that are responding and who are the patients that are not responding. To date, I think it's fair to say that PD-L1 positive patients have a higher response rate, but because PD-L1 negative patients respond as well, shouldn't use that as a distinguishing feature to offer the drugs or not yet. As far as first-line setting, I think we have to wait for the results. I think it's unlikely in diseases where chemotherapy has shown great benefit that monotherapy with checkpoint inhibitors is going to replace chemotherapy. But for example, if you look at lung cancer, there are at least 3 different ways that checkpoint inhibitors are being tested in the first-line setting. The first is combination therapy alone, which I showed you, Nivolumab and Ipilimumab, as combination immunotherapy without chemotherapy or compared to chemotherapy to see if it's as good or better in the first-line setting. A second option is in combination with chemotherapy, so first-line platinum-based doublets with checkpoint inhibitor. This is being done right now with, I believe, Atezolizumab in the first-line setting. So we'll see if that combination improves the results over chemotherapy alone. And the third is to look at a maintenance strategy where patients in non-small cell lung cancer would get chemotherapy first-line, and these patients typically get 4 to 6 cycles of chemotherapy, and then maintenance with a checkpoint inhibitor, and that's being done with Nivolumab. So I think there are a lot of different ways to skin the cat here, and whether or not these drugs become first-line agents in lieu of chemotherapy or combined with chemotherapy, we don't know yet.
Great, thank you. I think we can have one more question. And what do you think about combination immunotherapy compared with single agents with regards to affordability? Do you think cost will be a prohibiting factor?
Well, that's a very complicated question, and beyond the scope of the talk, we've been talking mainly about clinical results. There's no doubt that these drugs are expensive, and when we combine immunotherapy, if new drugs come out at where the old drugs are, we're going to be talking about a doubling of expense, which is going to run into several $100,000 per year that patients are on these drugs. And if you then take that very interesting result that maybe these patients should continue even after progression, we're talking about costs of drugs that are simply unsustainable. So at the same time we develop these exciting drugs and are benefiting cancer patients so substantially through immuno-oncology, I think it behooves the oncology community to also spend devoted time to figuring out how we can alter the reimbursement structure in such a way and the cost of these drugs to make them affordable.
Thank you so much, Dr. Schwartzberg.
All right, great. I wanted to say thank you so much to Dr. Schwartzberg and both to Dr. Ho for this wonderful presentation. And thank you so much to you and the audience for participating today. I also did just want to mention that we are very grateful that Dr. Schwartzberg is our ICLIO Advisory Chair. And hopefully you'll be able to join us in person for our ICLIO National Conference, which is coming up September 30th in Philadelphia. So please make sure you register and also take advantage of all the great resources we have on the ICLIO website. And again, that's accc-iclio.org. And don't forget to register for part 2. We have some really great questions that came in here at the end too. So hopefully we can get to those for the next webinar as well. So it's July 26th at noon. And register again at accc-iclio.org. Thank you so much, and everyone have a great rest of the week.
Thank you.